This is the presentation focal lung disease number 4, the last one. It will be for bronchogenic carcinoma, prepared by Prof. Mahmoud Sharaf and revised by Prof. Yusra Sabri. I'll give you some hint about what we were seeing before in bronchogenic carcinoma in the chest X-ray. We were saying that we have lesion at the hilum simply by if the hilum is prominent or if the hilum is dense. So unilateral hyperdensity and unilateral prominence of the hilum, or inequality of the hilum, or asymmetry of the hilum would suggest bronchogenic carcinoma in old age. This is first. Second, that persistent infection in old age for more than 15 days is considered due to underlying malignancy till otherwise proved. And with the advent of CT, we have a lot of signs which you can see. Number one, the airway obstruction. In airway obstruction, that means that we are occluding the lumen of a bronchus, and we have atelectasis, which is the most common sign, usually no air bronchogram, and we can have reverse S sign of Walden. We said that S sign of Walden is concerned with the fissure. If the fissure is shifted to the same lesion, that means S sign is positive. If it is bulging, if the fissure is bulging around a lesion, this is called reverse sign of Walden. That means there is something inside this area. There is a mass here. And another thing, if you have obstruction by a tumor, then distal to it there will be obstructive changes, obstructive pneumonia with either atelectasis or without. Number two, from either carcinoma or nodes, the hilar shadows will be enlarged either due to the carcinoma if it is central, or the presence of nodes draining a peripheral carcinoma. This is especially common in oat cell carcinoma and is uncommon in adenocarcinoma. Number three is the mediastinal node enlargement, particularly the small cell carcinoma. It could be unilateral or bilateral and asymmetric. So we can apply what we know in the chest X-ray film here, as mediastinal enlargement could be unilateral, bilateral, asymmetric, hilar enlargement due to nodes, atelectasis. Then lastly, we have cavitation, and this, although constituting 2 to 16%, some are considered as common, especially in squamous cell carcinoma, mostly in the upper lobes. Cavity usually is thick-walled, eccentric. The main sign is that there is a nodule inside the cavity, nodule along the margin, the inner margin of the cavity. That means that it is an eccentric cavity within a mass. This denotes malignancy. And finally, pleural involvement, either hemorrhagic effusion due to direct extension, and thus association with pleural hemorrhagic effusion denote bad prognosis or poor prognosis. Now, associated clinical findings in bronchogenic carcinoma, of course you know about the famous hormonal disturbances occurring in bronchogenic carcinoma, including hypoglycemia, Cushing syndrome, inappropriate secretion of ADH, excessive gonadotrophin secretion with breast enlargement, something like that. These are associations, but we have something clinically you can see. For example, in pancreas tumor, you can find Horner syndrome, ptosis meiosis, anhidrosis. Elevated diaphragm means phrenic nerve paralysis. Hoarseness of voice due to recurrent laryngeal nerve. Superior vena cava obstruction, as in small cell carcinoma with development of collateral on the surface of the body. Pleural effusion 10% in large cell undifferentiated carcinoma, you can find extension into the pleura. Dysphagia, that means nodes or esophageal invasion. By location, we have central bronchogenic carcinoma and the peripheral bronchogenic carcinoma. The central are two types, either squamous cell type or small cell type. The peripheral is adenocarcinoma and large cell type. So it is simply central SS, and the peripheral is adenocarcinoma and large cell carcinoma. What is the small cell carcinoma? It's called also oat cell carcinoma, and oat cell carcinoma usually presents with hilar mass, and the hilar mass is usually resulting in asymmetry or increased density or prominence of one of the hilar shadows. You might see or not a lung nodule. Rapid growth with superior vena cava obstruction and metastasis to the other side may be seen. And the associations we just mentioned now. Central bronchogenic carcinoma, we have here good example in the first slide here. That we can have mediastinal adenopathy, mediastinal invasion involving the vessels, superior vena cava, or involving the pulmonary vessels. Bronchial encasement, here it is reaching to the around the bronchus. Obstructive changes, here we have atelectasis, and there may be liver or suprarenal deposits. In this one, there is vascular encasement, tracheal encasement, and there is consolidation. Here there is mass, lymph nodes, and reaching to the periphery with mediastinal invasion and vascular encasement. Here we have cavity with irregular nodular inner margin, and here we have a large mass related to the central area, and it causes encroachment on the esophagus and encroachment on the right main bronchus. And here the mass is around the left main pulmonary artery. This is an example of unilateral hypertensy and prominence of the hilum, and here is on the other side hypertense or prominent hilum. But mind you that the changes in oat cell and small cell carcinoma is not so apparent like this. It may be just a minor change in density, minor change in size of the hilum that you should suggest the pathology. So as we said, the central type is squamous cell carcinoma or small cell carcinoma. The peripheral type is usually adenocarcinoma or large cell carcinoma, and the small cell is hilar, usually hilar and aggressive, rapidly growing. And these are examples of central bronchogenic carcinoma with distal atelectasis, distal consolidation, distal atelectasis, distal consolidation, encasement of vessels, cavity which is showing breaking down, and large mass invading the region of the esophagus. And here are the asymmetry enlarging hilar shadows. Peripheral bronchogenic carcinoma is usually presenting as usually in the upper lobe as in 70% of cases, and as we said, peripheral bronchogenic carcinoma is usually adenocarcinoma or large cell carcinoma. And here you can find that the mass is, while it's seen peripherally, yet it can present with hilar lymph nodes again, or it may extend into the chest wall. So we have you can have rib destruction or sometimes extension beyond the ribs, like here or there. Here is extension outside with rib destruction involving sometimes, if it is in the axillary region, it might involve the brachial plexus and subclavian vessels. Most of these present as liver and suprarenal deposits as well. So although peripheral, yet it can present with intestinal lymphadenopathy, and being peripheral, it may involve the chest wall, and being reaching to the chest wall and ribs as the region of the axilla may involve brachial plexus and subclavian vessels, and in all situations the liver and suprarenal glands are usually involved. So what is this? This is a large apical tumor with bone destruction of the ribs and adjacent vertebra. It's called as the superior sulcus tumor. It's a peripheral type of tumor, so it is a central type of tumor in a sense. That's why it is made of squamous cell carcinoma mostly. MR can assess the invasion of the brachial plexus if it is. Here, for example, there is encroachment. Here there is encroachment on the region of the brachial plexus and subclavian vessels, and encroachment on the spine. These all are better seen in MRI. So the spine, the subclavian, and the brachial plexus are well seen in MRI, while the bones, the destroyed ribs and vertebrae are well seen in the CT, and the whole thing is seen in just X-ray as opacity at the apex. May be small, may be large enough to extend and involve most of the lung. So what is this? This asymmetry of the hilum. There is dense hilum. This is a central type of bronchogenic carcinoma, which is the aggressive type, the odd cell type, and usually this leads to death within 3 to 6 months. Now this one is the left pancreas tumor with the opacity at the left superior sulcus here. This is the algorithm used to follow a solitary pulmonary nodule. If found on X-ray or CT, compare with previous. If no change within 2 years, ignore. If there are no old study, you are doing CT. If the characters are benign, like tuberculoma with satellites, hamartoma with popcorn calcification, AVM for example, so you will not do anything. In others, search about history of malignancy, or do follow-up CT scan after 3, 6, 12 and 24 months. If nothing, it is benign. If there is growth, you go and do biopsy. So finally, as you can see here, there is biopsy in case of suspicion, in case of growth. So in case of growth or suspicion, you should have needle biopsy, or otherwise you can diagnose a benign lesion, so stop. If you have follow-up for 2 years, you stop. Deposits in bronchogenic carcinoma can occur in the bone marrow in 40% at time of presentation, vertebrae 70%, pelvis in 40%, femora in 25%. Mostly they are mostly osteolytic in 75%, 3/4, while osteoblastic in 1/4. And the bone deposits in bronchogenic carcinoma are usually seen in small cell and alveolar cell carcinoma. 37% pathological adrenals are seen at the time of presentation in all cases of bronchogenic carcinoma. It's a big number. Metastases are also seen at the contralateral lung, kidney, GI tract, and liver. and in the GI tract it may be in the subserosal region or within the omentum. Staging bronchogenic carcinoma, if you have a tumor less than 3 cm not invading the main bronchus, it's T1. If it is more than 3 cm invading a pleura, invading bronchus, or associated with distal atelectasis, it's T2. If it is invading pleura, chest wall, diaphragm, pericardium, or invading main bronchus, stopping short at the carina, 2 cm from the carina, or with associated atelectasis, all are called tumor T3, but this is of any size. When it is large than the known 3 cm. So tumor 2 and tumor 3 are near to each other. Both are showing mass, which can involve a pleura, can involve a bronchus, can involve pericardium, chest wall, the nearby structure, can invade the main bronchi, but does not reach to the carina. And in all there is associated atelectasis. In tumor 4, it is a tumor of any size which is invading mediastinum and associated with malignant effusion. Nodal 1 means the same side, nodal 2 means the same side including the carina, and nodal 3 means including the contralateral side as well. As we said, this is an example of how to mix bronchogenic carcinoma with pneumonia. Here is the central mass, which is related to the dense left hilum, and it has distal atelectasis, while this one is a large opacity which is seen pointing to the hilum. It is following lobar distribution, likely to be pneumonia, but don't forget that such an appearance, if persisted more than 2 weeks, is due to central bronchogenic carcinoma as well. I think we discussed this before in aerospace pneumonia, as in the well-known pneumococcal pneumonia, or bronchopneumonia as staphylococcal pneumonia, or we have the acute interstitial disease, BCP viral, cytomegalovirus, and BCP and cytomegalovirus. Both are and ARDS all can give this appearance with reticulations. And this one is left apical opacity, as we said before, which can be diagnosed as a pancreas tumor, yet a long history with signs of chronicity and signs of left hilar strandy opacities. That means there are satellites with cavitation, is usually with tuberculosis and fungus. And this is the one showing round radiation pneumonitis due to post-operative radiation, with elevation of the diaphragm and absent breast shadow denoting mastectomy. So this is radiation pneumonitis. And finally, this is a triangular opacity with pulmonary embolism, so this is the appearance of pulmonary infarct. Consider this as a revision. Thank you.